Alright, so let's move on. Since we're talking about high dosing of methylphenidate, now we're going to talk about ADHD and narcolepsy and the relationship in between them. So yes, dopamine and narcolepsy are connected, but narcolepsy is not primarily a dopamine deficiency disorder. So narcolepsy versus dopamine. In narcolepsy, the major abnormality in type 1 is the loss of hypocretin and orexin-producing neurons, not loss of dopamine neurons. However, orexin normally interact with several arousal systems, including the dopamine system. So therefore, orexin neurons influences the dopamine pathway, therefore influences the wakefulness, motivation, attention, and alertness, which is obviously ADHD. Orexin-producing neurons are located in the hypothalamus. When you're awake, they activate and reinforce several other arousal systems. When orexin signaling is lost, dopamine signaling and other arousal systems can become dysregulated. Research has found alterations of dopamine transmission in narcolepsy, but this is different from having the profound dopamine loss seen in Parkinson's disease. So we're talking about everything now. I've talked about several things before, and now we're kind of putting it all together. All right, so the one reason that orexin and dopamine relationship is relevant is when we're discussing narcolepsy and ADHD. So, could low dopamine make narcolepsy symptoms worse? Well, potentially yes. Reduced dopaminogenic activity can contribute to excessive sleepiness, reduced motivation energy, difficulty maintaining attention, slower cognitive performance, and reduced alertness, which is all part of ADHD. But these symptoms aren't specific to low dopamine and can also occur from narcolepsy itself. Depression, ADHD, insufficient sleep, which is caused by obviously other reasons. Medication, wrong medication, trying medication, sleep apnea, that is something that's totally different in what I'm thinking, and other conditions. I mean, sleep apnea does really not have anything that I want to talk about that influences dopamine and ADHD. So, an important distinction. Parkinson's disease, the main neurotransmitter problem is the decrease in dopamine in night growth striatal pathway. Night goes striatal pathway. I looked it up. So, anyways, ADHD is dopamine and neuroepinephrine signaling defenses. While narcolepsy type 2 is orexin, usually relatively preserved, causes are less clear. So if someone has narcolepsy plus symptoms suggesting low dopamine, it's worth considering whether there's a second condition or medication effect, rather than assuming narcolepsy itself means dopamine is low. ADHD and narcolepsy can also coexist, and they can look surprisingly similar because both can cause problems with attention, concentration, and daytime functioning, as well as falling asleep, like me, without my methylphenidate. So, alright, so why they can be confused. Someone with narcolepsy may appear to have ADHD because severe daytime sleepiness can produce inattention, forgetfulness, poor working memory, impulsivity, and difficulty in completing tasks. And that also has to do with, obviously, your sleeping pattern, how you sleep and stuff. Conversely, someone with genuine ADHD can have significant daytime fatigue, particularly if they have poor sleep or their dopamine is not enough to wake them up. There's also evidence that ADHD is diagnosed more frequently among people with narcolepsy than in the general population, suggesting that the two conditions can overlap. They're not mutually exclusive, rather than simply being two names for the same symptoms. When both may be present, a person with both might experience for ADHD, difficulty sustaining attention, executive function problem, distractibility, impulsivity, hyperactivity. For narcolepsy, overwhelming sleepiness, involuntary sleep episodes, sleep paralysis, vivid dreams, and possibly cataplexy. The combination can make daytime functioning particularly difficult for the patients. So one important clue is that if someone has been treated for ADHD but continue to have uncomfortable sleepiness or actually falls asleep during conversation, work, reading, driving, or other activities, I would never drive without methylphenidate. Narcolepsy or another sleep disorder should be considered rather than assuming that ADHD treatment simply isn't working. Lastly, diagnosis generally involves a sleep specialist, overnight polysomnography, and, when appropriate, a multiple sleep latency test, MSLT. So think about it, look it up. I found myself, because my tolerance is so high and I've been on it for so long, my body relies on it. So yes, I'm awake right now because I'm on a proper dosage of 20 to 30 milligrams, and I started with a little schedule that I'm just gonna show you guys. Oh, here we go. It's a little schedule right here. Where I actually track the methylphenidate that I take and try to be optimal given the circumstances that I'm under with people stealing my medication, breaking in. I really miss hyper-focusing, and I used to pick up twice a week, and now it's every single day. It's very difficult for me to sustain my attention and irritability, actually. Sometimes when you're underdosing, it is just as harmful as overdosing. And well, obviously overdosing can kill you, underdosing doesn't, but it makes you feel like shit. So that's the end of it. I don't feel like shit right now, but maybe I will later on. Take care.